good morning for me, but good afternoon, good evening for all the others. I'm very excited to co-chair another webinar supported by UPSA, together with my friend and colleague Martin Lacher. Sorry for my voice, I'm at home recovering from COVID. Today's webinar is entitled Indocyanine Green ICG Enhanced Fluorescence in Pediatric Surgery. And we have two exceptional speakers who've been working a lot on this very novel topic for pediatric surgery, which is in fact the use of ICG. So we have Professor Ciro Esposito from Naples, and I would say Mr. In the British way, Stefano Giuliani from Great Ormond Street Hospital in London. Thanks everyone for joining in. We already have more than 70 participants, and of course we'd like you guys to tell us where you come from, and as usual in our format, it will be the two speakers giving their presentations. It will be about 50 minutes each, and then afterwards it will be a Q&A session where you can actually ask questions, drop your questions in the chat, and then Martin and I will address your questions to the speakers. So without further ado, I start introducing, how should I address you, Stefano? Doctor, Mr., Professor?
As you like, call me friend. Stefano is perfect. Augusto, thank you for the introduction. Yeah.
Shall I say, Mr. Giuliani is a consultant pediatric surgeon at Great Ormond Street Hospital in London. Our friendship goes way back when we were both training in Italy, and in fact he got his full pediatric surgery certification from the University of Padua, that, for the ones who don't know, is first of all the oldest medical school in the world, but it's also a leading center for pediatric surgical oncology and kidney transplant in Italy. And after his degree from Padua, Stefano went on to get further training in the United States, and specifically with Dr. Ford in Children's Hospital Los Angeles. Dr. Ford is the current president of the American College of Surgeons. So Stefano has an amazing mentor, of course, throughout his career. And then when he came back to Europe after this American experience, he started practicing as a pediatric surgeon, I think for a little while in Italy, and then was recruited as a consultant pediatric surgeon at St. George's in London, one of the biggest pediatric surgical oncology centers for the English capital, where he was between 2011 and 2016, and then he was recruited, headhunted, I would say, in 2017 by Great Ormond Street, where he, in fact is then still there and working with special interest in neonatal surgery, surgical oncology, thoracic gastrointestinal and minimally invasive surgery. And in the last few years, I would need another 10 minutes to go on and tell you guys about all his achievements and his CV, which span also between research and leadership, but then I would take up too much time. And so you've done a lot of research, also basic science research, but most recently you've concentrated on ICG and the technology behind ICG. So I leave you the microphone, because we're really at the edge of our seats, to really curious to hear about your journey with this new tool in the armamentarium of pediatric surgeons. Thank you, Stefano.
Thank you very much, Augusto and Marty, for inviting and for the kind introduction. I'm gonna share my screen. Tell me if there is any problem. Can you see it well?
Perfect.
Perfect. Okay, thank you again. This is a topic that I'm really in love with because it combines innovation with translation, which is, as a surgeon, for me, one of the most important things to really bring from the lab into the operating theater, new discoveries and new things or devices that can help surgeons to make a better job. So this is an overview on my presentation. I will give you the general basics for fluorescence-guided surgery, and then I will give you some clinical examples about the application of Indocyanine green fluorescence in general pediatric surgery, in specialist neonatal surgery, and oncology surgery. And then I will give you a very brief overview at the end about the future of this technology, particularly in regards of what we are doing preclinically in the lab with targeted fluorescence-guided surgery for tumors, and the development of novel devices that can make basically the imaging better. As you probably know, I'm sure most of you have seen and used this technology before, but basically you need three elements for fluorescence-guided surgery. You need a dye that is a fluorescent dye that, in this case, again, clinically, Indocyanine green is the most commonly used fluorophore. But there are other actually dyes like IR dye 800, which is a fluorophore for fluorescent that has been used conjugated with monoclonal antibodies in clinical trial for targeted fluorescent-guided surgery for cancer. Then you need the light source because the light will need to excite the dye and create an excitation of electrons that are producing an emission of light. So there is an excitation and then an emission of light, and you need to have a special camera that has either a laser or a LED to excite the dye, and also a camera to collect the image and the light that is emitted by the dye. So it's pretty straightforward, this one. In particular, in terms of dye, I mentioned Indocyanine green. In Europe and in the UK, the company that produced the dye has called the dye Verdye, and the current dose is basically not a single specific dose, but is a range of dose can be used in children, and is between 0.1 to 0.5 milligram per kilo. This dye has been around for more than 50 years, has a very safe profile of use, have a very short half-life of about 3 to 4 minutes, and it gets attached to plasma proteins, and then it gets excreted through the liver into the bile. And as you can see here, there are two curves, just if you want to be a little bit more scientific here, and the wavelength for excitation of the dye has a peak that is at about 790 nanometer of wavelength, and then the emission, so the camera that needs to collect the image, around 810, 815 nanometers. As you probably know, the most common indication is either to visualize blood vessels or to assess perfusion of intestine or other organs. On the other side of the game, you have a device that needs to excite and then collect the image. And as you may know, in the last decade, there has been, a very flourish market of new devices. And this is quite daunting in a way for surgeons to understand what is the best device, but also to understand if the image that we get with one device is comparable with image obtained with another device. And this is not necessarily true. So just to show you some of the limitation also of the technology with my presentation, I want to say that basically the software and the hardware that is used by different devices are completely different technologies, and they can produce an image that is different, even using the same dose in the same patient of dye. And this is a limitation of the current technology. Now, going a little bit more on the indication, I mean, the field, as often happens in children, has been pioneered by adult surgeons, and the indications are very similar. I think it started with the visualization of extrahepatic biliary tree, particularly to make the laparoscopic cholecystectomy safer, bowel perfusion, and then tumor visualization, lymphatic visualization, etc. I mean, the technology is still behind compared to what the adults are doing, but actually, even in the adult field, this innovative technology is still kind of at the beginning of the development. So it's quite exciting field. So let me show you some of the common applications. So first, the fluorescent guided surgery can be used to visualize better anatomical structure and to avoid to damage, for example, the ureter. There are some stents that they carry some of the ICG inside, some ureteral stents that can be seen and inserted with the cystoscopy before the operation and then be visualized. As we know how difficult it is, particularly for paraspinal thoracic neuroblastoma, to visualize a thoracic duct, or in case of an injury to actually visualize the leak from the thoracic duct. And as you can see here, there is already a kind of standardized dose that can be injected in the groin, usually an hour before the surgery, to visualize the thoracic duct. Regarding the biliary system, again, the dose, there are different indication and different dosing, but 0.5 milligram per kilo intravenously given a few hours before the surgery, I will explain you why, is the ideal for visualization of the biliary system. I'll give you a few examples of what we have used Indocyanine green fluorescence for. So this is a 16-year-old boy who had a recurrent hiatal hernia, and the first Nissen fundoplication was done at the age of 1. So he had a quite complex abdomen with a lot of adhesions. And as you can see here, on the left-hand side, you have the traditional view, which is showing a stomach that is stented up to the abdominal wall because there is a gastrostomy. There are a lot of adhesions between the liver and the stomach. There is a lot of adhesions between the liver and the right crus, which is basically the area that we need to free up and clear to then perform our redo Nissen fundoplication. If you look on the left, there is nothing that we can see about vasculature there. But if you look at the monochromatic view, which is probably the most accurate view that we can gather with the fluorescence guided surgery. I mean, the green fluorescence is fancy, but the black and white image is probably the most sensitive one for us to visualize the blood vessel. And you can see here, you can see that there is a small vessel just behind the adhesions, and you can see exactly where you can cut the tissue to avoid to injure that blood vessel. Now, same case here, you can also actually localize quite well and in an easy way, I would say, the right gastric artery, which is pretty important to preserve. It can be used as a landmark to understand where to make the window behind the esophagus to then pass the fundus of the stomach for the Nissen. And I think it is very clear here on how easy it is to visualize this vessel to avoid injury, which is not straightforward, particularly because of the adhesions in this case. Now, going back on more specialistic surgery, neonatal surgery is something that we all love and we all do, and there are challenges not only because of the size of the children, but for example, duodenal atresia with the web, we know how difficult it is to decide where to do our incision into the duodenum, to basically remove the web, or to do a duodenostomy. And this group from Asia has shown that actually injecting Indocyanine green into a nasogastric tube, so into the stomach, it can show us exactly where there is the obstruction and the duodenal web, as you can see here on this photo on the left. And then you can easily place your duodenotomy, proximal and distal, and then perform your duodenostomy. And then after that, you inject again in the stomach, and you see if the contrast is moving forward and is reaching the jejunum. So very smart application that we can use very easily, even without injecting in the bloodstream. Now, we have used extensively this technology for anorectal malformation, for other colorectal cases. Again, here is the perfusion that we want to assess. We know that after the dissection, particularly in high anorectal malformation, we are always a little bit uncertain about the level, the degree of perfusion, particularly at the most distal end of the bowel, of the rectum. And as you can see here, you can track actually a very good vessel on the left-hand side to understand what is the area that is well perfused and what is the area that we should actually chop out before doing the anoplasty that is, you can see on the right-hand side. And then, we did this with Elevision, which is a a very good device from Medtronic that can actually give us different setup, and the setup for the skin is more sensitive and different than the setup for perfusion of the bowel. So we can actually tailor our imaging based on what type of surgery we are performing. And they're quite exciting. But again, it's not comparable between devices, which is not great at the moment. This is a case that I've done with Professor De Copi, who is an expert in neonatal pancreatic surgery. As you know, congenital hyperinsulinism, particularly when it is diffuse, will deserve a near total pancreatectomy, so removing the majority of the pancreas. This is done openly in most of the centers around the world that are specialized in this technology, in this technique, because basically the identification of the common bile duct has been really challenging. But I believe that this application has dramatically changed the way we do surgery in these small neonates using a laparoscopic technique to perform a near total pancreatectomy. You can see here that basically the pancreas is all gone, and the common bile duct is skeletonized and very visible, and then there is just a small amount of head of the pancreas just around the papilla of Vater that has been left in place. Very exciting. Same thing can be done for a focal lesion, and this is a pre-operative assessment of the FDG PET scan that shows a focal lesion in basically at between the body and the head of the pancreas. As you can see here, this is what you see laparoscopically. It's quite difficult to see a nodule or to localize anything that is abnormal. And in the past, we used just to take a biopsy and see if there was any focal lesion. But as you can see here now, is very well demarcated. And this happens because the vascular anatomy of the focal lesion is different than the vascular anatomy of the normal pancreas. So basically, the ICG runs highly in a hypervascular focal lesion. And this is pretty intriguing. You can see also the fluorescence ex vivo when we have removed the nodule. And again, the monochromatic is really the best way to visualize this. Now, thinking about perfusion of the bowel, it is not a standardized field at the moment. So there is quite a lot of research, particularly in adult colorectal surgery, but the level of intensity is not necessarily the best assessment of perfusion. And as you can see here, basically there is a fluorescent to time graph, which is very simple. Basically, you assess the perfusion before injecting, and then you inject the dye IV, the Indocyanine green, and then there is a lag time, which is T0, until the fluorescence starts to happen. And then there is a slope that reaches a peak, and the peak of fluorescence, again, is not necessarily associated with the quality of the perfusion of that piece of bowel, but actually there are other parameters on how quick the slope, how fast, the Indocyanine green reaches the peak intensity. And this parameter in adult surgery has been associated with clinical outcome, such as the risk of having an anastomotic leak. In pediatrics, we don't have any information about this, but again, we do not have a gold standard quantitative assessment of perfusion, and this is still a big gap in the field. So just to show you a few cases, this is a total colonic ganglionosis that has gone through a Duhamel procedure. This is the bowel, very well perfusion, proximal to the distal bowel that will be brought down for the anastomosis in the distal part of the rectum. But here, as you can see, this is basically the perfusion at the same moment in time. As you can see here, the white light image shows a pretty well perfused and pink piece of bowel that we have anastomosed. But when you look and you try to assess the percentage of perfusion compared to the comparison, which is the normal bowel that I show you here, there is about a third of the dye that reaches the distal part. So what does it mean this clinically? This is still unknown. So the images are very fancy, are very cool, and they can help particularly to differentiate normal anatomy and vital structures. But in terms of perfusion, still we are kind of far away from defining gold standards of care, and particularly in association with the outcome. This is another simple case of an ileostomy closure. As you can see here, the white light image shows a discrepancy in caliber. You have a proximal dilated bowel and the distal one that is not dilated. Usually this is 1 to 2 kind of difference in caliber. And as you can see here, this is the filling period. So going back to that curve that I'm showing you, is not only the intensity, but is how long does it take for the bowel to have the green, basically. And it took 25 seconds from injection. And as you can see here, the area, particularly the proximal bowel, at the edge where the anastomosis is going to be done, is still darker than the distal part. So what does this mean? It is still not known. So it is 76% perfused compared to a proximal piece of bowel that is completely well perfused. And this is the same assessment done on the distal part, which is 85%. But again, these are numbers that at the moment, they don't have clinical value. This is post-anastomosis. We injected again, so ICG can be injected few times to reach a maximum dose of 0.5 milligram per kilo during the surgery. Now, briefly, just an overview on oncology. ICG has been proved to be effective in certain pediatric tumors, and we have Luca Pio, who is an expert on this, together with a group of oncology surgeons, has recently published on Annals of Surgical Oncology a review of the literature considering only the pediatric oncology cases where this technology has been used with ICG. And again, there are 233 patients that have been treated and used with this technique. And again, we can visualize head and neck tumor, we can visualize lung metastatectomy, particularly for hepatoblastoma, lymph node sampling, particularly for Wilms tumor or other sarcoma, so like sentinel nodes, nephrospastic surgery, etc. So in oncology, I mean, this technology has limitation in the sense that the uptake of the ICG into tumors is variable, and basically it is based on enhanced permeability and retention. So we know that tumors have a disrupted and abnormal capillary and microcirculation, and there is a capillary leak there compared to normal surrounding organs. So the ICG goes out of the bloodstream and gets basically stuck into the extracellular matrix of the tumor, and it stays there for longer compared to normal tissue. So this is how it works. Now I'm going to go quick here. I want just to give you the knowledge, basically, that there are a lot of papers showing when and how much to inject for hepatic surgery, for hepatoblastoma or peritoneal deposits. This is based on, again, the excretion of the indocyanine green from the liver. So as I said, the half-life is very short. So ICG goes straight to the hepatocytes and then it gets cleared out in the first 24 hours. So it takes 24 hours for the liver to be without fluorescence, which is what we want. And the tumor, as I said, will retain ICG for longer. So for liver surgery, a minimum of 24 hours of lag between injection and surgery needs to happen. Of course, the dye from the liver goes into the duodenum and small bowel, so you will have a background fluorescence coming from that, from the intestine. And for this reason, the recommended timing for fluorescence for liver surgery is 72 hours. Now, the problem is that because it is not targeted, is not homogeneously lighting up the entire tumors or the entire residual of tumors or the entire disease. In fact, post-chemotherapy, for example, in hepatoblastoma or certain histotypes of hepatoblastoma like teratoid or poorly differentiated tumor, they actually have an uneven fluorescence pattern. That means that is not reliable for margin visualization or for residual disease. So we need a different technology. This is for lung metastasis. Hepatoblastoma is very avid of ICG. So with this dosing and 24 hours of lag between injection and detection is basically the right timing at the moment to visualize lung lesion. I mean, there is quite a good experience from Max Planck in Birmingham here in the UK. and Abdelafiz, who is an expert from St. Jude Hospital, were basically injected ICG to guide the lymph node dissection in Wilms tumor. They've used a slightly different technique, one injecting in the hilum of the tumor and one injecting subcapsular, and they have achieved the same visualization of basically the local regional lymphatic chain, where it is easier to visualize lymph nodes, which is again a challenging thing in Wilms tumor. Now, really few more words here on the future. There is a lot of work to do. There is a lot of research to do. So I will invite you really to start looking into this field, which is very exciting. And particularly, I want to talk
Stefano,
about...
sorry to interrupt. We need to come to the conclusion because we have only 1 hour and a half hour.
Absolutely. Absolutely. I'm just talking about, the targeted fluorescent gamma surgery where we use a monoclonal antibody and a fluorophore attached together. So the dye will selectively attach only to the cancer cells. And there is a few different imaging technology that we can use to visualize in a more specific way, particularly small residual. And this is important because all the medical devices that we have are imaging in the near-infrared fluorescence, which, as I showed you before, are targeted against the emission and excitation spectra of ICG, which is between 750 and 950, which is the near-infrared one. Now, if we move higher on the wavelength, we reach the short wave infrared that has higher penetration and better definition. I mean, I can just skip this video, which is targeted fluorescent gamma surgery for neuroblastoma in preclinical study. This is the last slide that I have, where basically I show you the difference between the current fluorescent guided surgery in the near-infrared one spectrum for ICG. You see how much background noise you have, and you see how unclear the margins, particularly when you have a small residual, are, to actually move in the shortwave infrared where your image becomes crispier and the definition is way higher. And this is particularly important in cancer surgery to make sure that your margins are clear from disease, in sarcoma surgery, in liver surgery, in lung disease, etc. So in conclusion, the technology has multiple indications in children, and I would suggest you to start adopting this. It is safe, and it can guide and make your surgery safer. There is the need of more prospective studies to define better the standards. And again, I believe targeted fluorescent guided surgery, particularly for solid tumor, is the way forward. And novel imaging devices for multispectral, hyperspectral imaging are the future, because they're going to give us a better image that possibly is more standardized and better to be compared. I want to thank all the collaborators, clinical collaborators, colleagues, and basic scientists that are working with me. And again, we hope we can transform maybe the killing curse into an effective way to visualize better and to facilitate our difficult job. Thank you very much.
Thank you, Stefano, for the beautiful overview. Before we come to the questions, I will introduce the second speaker of this afternoon, which is Professor Ciro Esposito from Naples. He does not also need much of an introduction. He's a full professor of pediatric surgery at Federico II University of Naples. He is chief of pediatric surgery at that institution. He is COO of ESPAS, and in fact, he's vice president or president-elect of the IPAC. He's an honorary member of several national societies and director of Regional Reference Center for Pediatric MIS and Robotics in Naples. The list, which I could lead through, is much longer, but Ciro, if you forgive me, I will stop here. Ciro has been a friend for many years, as we share the same passion of pediatric MIS, and he has been organizing and leading international courses in pediatric MIS throughout the world, including being faculty for many years of the EARCUT courses since 1996. The two courses he gives in Naples, which are of great quality and with outstanding hospitality, as I had the privilege to honor to experience twice. and of course the courses, the MIS courses during the annual meeting of the UPSA. Professor Esposito has 470 publications on international journals, which high impact factor, 115 book chapters. He's editor of 13 books of pediatric urology and surgery, and his age index is 51. So Professor Esposito, dear Ciro, it's a big honor for us to have you with us tonight to listen to your talk on the applications of ICG in clinical surgical practice.
Thank you very much, Martin. Thank you very much, Augusto. It is a true pleasure for me to be here with you and to Stefano to share my experience on ICG technology. I will share my screen. And I would like to start to show you my 7-year experience using ICG fluorescence technology in pediatric surgery. Why to adopt ICG? In this video, you can see a cholecystectomy in the pre-ICG era. As you can see, there is a dilatation. The anatomy is not very clear. In these cases, there is an high risk to have a complication. And then this is the ICG era. As you can see, this is a case of a cholecystectomy. There are a lot of adhesion due to inflammation, but thanks to ICG technology, you can identify the gallbladder that is colored in green, and then you can guide the green to have a dissection of gallbladder without having complication. I think that this case was impossible to perform without ICG because there are too many adhesions. And this is another case of splenectomy. It's difficult to identify the splenic artery. You inject ICG, the artery became green, and you can easily identify it. The reason to adopt ICG, for sure, to guide the dissection in complex cases, to reduce the incidence of complications, to perform a safer surgery and a faster surgery, and above all, if you have a training program, is a fantastic fashion to train new generation of surgeons. We published some papers on this topic. In my multimedia hybrid operative room, I have the STORT system, then Rubina system that use this technology, and I will show you some videos. If you have a Da Vinci XI robots, as Stefano already told you, there is the Firefly mode that you can use ICG also in robotic surgery. And these are the indications that I tried in my experience, but probably in the future will be more indication, as already shows Stefano in his slides. Probably the main indication for pediatric surgeon is cholecystectomy. Why? Because, as you know, compared to adults, we perform few cholecystectomy per year, no more than 10 to 30. For this reason, sometimes it's not easy to do it, and we need something that can reduce complication. As you know, ICG is a fluorescent dye, and you can, for cholecystectomy, you have to inject intravenously, and this bound plasma proteins is taken up by hepatocyte and then excreted in bile. In this way, you can identify the gallbladder. It's important to decide the dose and timing of injection. There is the vial of ICG. You have to dilute the vial with 10 milliliters of sterile water, and then you have to inject 6 milliliters. We have to inject, in my experience, for cholecystectomy 12-15 hours before to avoid having the liver green. In this way, you can have only the gallbladder in green. As you can see, the fantastic view of the anatomy that you can have. The gallbladder is green. You can see very well the cystic duct, the main biliary tree. The fatty tissue is yellow and is easy to perform the dissection. You can see the gallbladder artery very clear. I think thanks to this technology, the anatomy is absolutely amazing. Also, in case of adult cases, this is a 16-year-old boy, you can see the cystic duct a little bit dilated, and there is an anomaly position of gallbladder artery, but thanks to ICG, you can perform easily the dissection of the artery that is colored in red, while the gallbladder is colored in green. And you can identify also the anatomy. As you know, there is one of biliary anatomy, Luschka duct, are duct that came from the hepatic bed or gallbladder directly, or gallbladder are difficult to identify, but if you have Indocyanine green, you can identify them. As you can see, we removed the gallbladder, but we found a small duct, Luschka duct, that if you leave this duct open, you can have a complication after surgery. Thanks to ICG, you can identify clips and avoid complication. In renal surgery, I have a Da Vinci Xi robots. This is a case of nephrectomy. Above all, you can use it in case of tumors to identify nodes or to identify the vascular anatomy of the kidney. But I prefer to perform kidney surgery in laparoscopy, and then one of the main indications to use ICG for renal surgery is partial nephrectomy. It's useful for three reasons. First of all, we have to perform before surgery, you have to put a stent in the normal ureter, and you have to inject ICG inside this catheter, and you can see how the normal ureter is colored in green, and then you can dissect the normal ureter from the dilated ureter of the moiety that you have to remove. The ICG guide your dissection, avoiding to have a danger on the other ureter. As you can see, after the dissection, the normal ureter is on the down of the screen, and the dilated ureter you can section, and then you can follow the ureter to arrive to the moiety that you have to remove. A second injection you have to perform intravenously when you have to identify the vascularization. You can see the main disease, an upper pole partial nephrectomy. You can see the renal vessels, and then the upper polar vessels colored in green, and you can treat them, clips and section. And then at the end, a last injection, the moiety is normal vascularized, while the moiety that you have to remove is not colored, and you can fight the plane of dissection. Other indication, recently, following the François Varley experience, we start to performing gynecomastia using pediatric endoscopic subcutaneous mastectomy. We perform this procedure position 3 trocarlaterally on the medullary axillary line, and the difficult part of this technique is to remove the gland. If you inject transcutaneously through the nipple the green in the gland, during the procedure you can easily identify the gland that you can remove using endoscopy. Or if you perform the anal fistula using the fistuloscope, you can enter into fistula, you can coagulate all around, you can inject green, and then you can enter into the anal canal, and you can see if there is an orifice, there is the green, and you can identify the orifice, and you can close it via transanally. For sure, one of the main indications is the treatment of varicocele. As you know, if you perform Palomo procedure, if you ligate the lymphatics, you can have an hydrocele in postoperative period in about 20% of cases. Thanks to ICG, you don't need to have hydrocele. You inject the green inside the testis, 1 millimeter of solution, and you can identify the lymphatics. In general, there are 4 lymphatics. To avoid having an hydrocele, you have to skip at least a couple of lymphatics. It's absolutely easy to do and extremely clear. And you can use monochromatic or blue software. You can change your image as you prefer. Also, if I think that the green one is better. For sure, Stefano already told you the possibility to use this dye in oncology, above all for pulmonary metastasis in case of hepatic tumor. You inject intravenously, and the hepatic metastases are green colored. For this reason, I think is another good indication. Or in case of lymphomas, this is a case that we perform in thoracoscopy. You inject the dye inside the lung, and then you can define the pathologic node to remove that are green colored. For this reason, I think there are a lot of indication to discover. And for partial splenectomy, it's the same principle of partial nephrectomy. You can use it to identify the vessels, and also after clipping the vessels of the part of the spleen that you have to remove, you can check the normal colored spleen. This is the blue software. You can see the upper part of the spleen is not colored, that you have to remove, is a kyst, and the lower part of the spleen is normally vascularized and blue colored. There is the line of dissection. And also, in case of emergency, in case of the nasal torsion, you can taste if the gonad is normally vascularized before and after the torsion. Is a test extremely important to do. You can perform the torsion, and then you can check if the gonad is normally vascularized. And recently, we have the possibility to try also ICG-guided technology for open surgery. And we published recently a preliminary paper on this topic. This is a video-assisted surgery. There is a special camera that you can put on a metallic arm, and you can perform also ICG technology for open procedure. This is my fantastic operative room enables. We have multi-screen system, and using 4K HD ICG technology, you can use also to remove some lesions, as you can see in this case, or lymphangiomas. You can inject transcutaneously directly into the mass, and then you can follow the dissection. It's extremely important because you can guide your resection. This is only a preliminary study, but I think that there are a lot of options also for thyroglosal duct cysts. Sometimes it's difficult to identify the fistula, and you can follow the green, as you can see, that can guide your dissection. In some consideration before concluding, as Stefano already told you, you need special equipment to perform this technology. You need the camera, the optic, and the ICG vial. There are several brands that produce now the ICG camera on the market. The timing of injection can change accordingly to the indication and the organ to study. For example, for cholecystectomy, you have to inject the day before, and is intravenously. For other indication, you have to inject directly into the organ that you have to study. I think that using this technology, there are real advantage for surgeon. There is no adverse effect in our experience. When you perform the solution, you can use the vial for 6 hours. It means that you can use the vial in the morning for several procedures. In conclusion, I think that ICG fluorescence is safe, useful, and versatile technique that you can adopt in MIS to achieve a better visualization of surgical anatomy, and above all, to have an easier dissection. I think that the main advantage is, thanks to ICG fluorescence, can help surgeons to reduce complication, and I think it can be considered in selected cases to increase safety of laparoscopic procedure. And thank you very much of your attention.
Thank you, Ciro. This was a fascinating overview of so many applications, and thanks also to Stefano with the specific focus on neonatal and oncology surgery. So first of all, I would like to say that there's been about 120 people listening to you live. This webinar will be it is recorded and will be then uploaded on the UPSA YouTube channel on Stay Current. And so we know that there's going to be even more people that will see your presentations. And there's a lot of pediatric surgeons from all over the world. It's of course, as we always know, it's sponsored by UPSA. We think about the European boundaries, but actually we have people from really all over the world, including Trinidad and Tobago, Pakistan, Argentina, Mexico, Los Angeles. So this is, as you know, plus of course all the Europeans that have been listening to you. This is the power of our technology these days. If you don't mind, Martin, I kick off with the first question. This is a question from Dr. Ahmad Elatab, who asks if ICG can be helpful in confirmation or exclusion of the diagnosis of biliary atresia. This is a very, very interesting question. This is for both of you, Stefano and Ciro.
Yeah, I can start, Ciro, if you like. I mean, I've seen few reports on this. I've not used it myself because we don't do biliary atresia at Great Ormond Street. It goes to King's College in London. But basically, there are reports from Asia where they've done either case reports, but actually there is a case series where they publish, you know, the traditional kind of confirmatory diagnosis of biliary atresia with a laparoscopic biopsy and a cholangiogram intraoperatively, but also they were injecting ICG and see if the ICG could reach the gallbladder and the common bile duct. And they found, you know, some cases where both the traditional standard of care could not actually confirm the diagnosis intraoperatively, so with the cholangiogram, but actually the ICG could reach the common bile duct and the duodenum and exclude biliary atresia. So it is possible, and I think it's supporting the standard of care that we have now to confirm intraoperatively the disease.
Yes, I agree with Stefano's comments. I think that ICG can play a role also for biliary atresia. I have no personal experience, but as Stefano told us, there is some reports from Asia, and I think that probably can help a double role, because if you perform this technique to correct biliary atresia in MIS, you can use MIS technology, but with the recent advanced, as for ICG technology, you can use also ICG for open surgery. For this reason, also, if you correct biliary atresia in open surgery, you can adopt the same technology, and probably in the future will be an indication to use it.
I mean, another quick comment on this, you know, it has also been used to assess, you know, the porta hepatis and if there was any bile drainage, you know, for the portoentero anastomosis. So it's a technology that, particularly in Asia, has been employed extensively, as we know. Yeah.
They definitely have also a higher number of cases of biliary atresia, and they're quite advanced. Just had the pleasure to attend the PAPS conference, and definitely Asia. I see somebody in the chat from Malaysia. They're at the far front of the technology, including ICG. Martin.
Yeah, I also have a question. So you proposed extrahepatic bile ducts, bulb perfusion, lymphatic visualization, and tumor visualization. So which of the four do you think is, at this point, the most suitable application where it really makes the biggest difference?
Please, Stefano.
So for me, the visualization of the extrahepatic, you know, biliary tree is making a difference in the understanding of the anatomy, and Ciro shows a very good video of it. But, you know, if we look at the adults that are, you know, actually a little bit ahead of us, basically in adults, this technology is becoming the gold standard and is reducing the risk of bile duct injury. And if you don't use it, I think the lawsuit that you're going to have will be really hard to defend if you don't use ICG. So again, as Ciro has explained very well, because our numbers are small and still we can have difficult cholecystectomies, I think that is, for me, at the present, the gold standard, and I do not do a gallbladder without it now. But the perfusion is not clear. It's not clear what it means. It's cool, but it's not going to change anything. And also for the pancreatic surgery, which is still extrahepatic biliary. For the tumor, I think for the lung lesion, for hepatic lesion, it is quite helpful because at the moment, the way, for example, to identify, to localize lung lesion is tricky. The main limitation of ICG in the lung metastatectomy is the penetration depth. So you need to basically to have possibly single lung ventilation to keep the lung expanded, and you have less than 1 centimeter penetration depth. So you cannot see fluorescence deeper than that. And this is a little bit of a limitation. So these are for me and then the lymphatic is also important because actually for the Wilms nephrectomy and for the sentinel node, it's a technology that I use and is effective.
I think that we can divide the indication in 3 areas. The routine surgery, probably the main indication are cholecystectomy and varicocele. Because for cholecystectomy, as I showed in my second video, in case of adhesion, it's absolutely fantastic to identify the gallbladder that becomes green. Sometimes if not clear, the anatomy, thanks to ICG, is absolutely clear, and you avoid having a complication. Above all, is a trainee that performed the procedure. The other routine procedure is varicocele, as you know. For those that use laparoscopy to perform Palomo, in general, there is a ligation of lymphatics, and thanks to ICG, you can spare the lymphatics. Then the second area is the emergency, probably thanks to the open ICG system. In case of testicular torsion or at the next torsion, you can taste the vascularization after the torsion. I think is absolutely fantastic because usually you put the testis not water to check the vascularization, but thanks to ICG, you can have a clear image and also the percentage of vascularization thanks to the technology. For advanced surgery, for sure, tumors is an application. The other is for partial nephrectomy. I think identify the ureters, the vascularization is fantastic. And probably as Stefano showed us, in case of intestinal anastomosis, you can identify the vascularization of anastomosis. I think is absolutely useful. But I think that probably new indication will appear in the near future using this technology in our routine practice.
Mm-hmm. Thank you for sharing your experience. So there's Ciro, you showed us that case of, I think, ovarian torsion. And I'm still not sure if I don't see any perfusion whether I would do anything. I think I would leave the ovary. But there's a question in the chat whether you can diagnose a torsion of testis with the ICG.
As I told you, we taste preliminary the new Storz platform or Rubina lens in open surgery. We taste in a couple of patients of testicular torsion, and this is extremely useful because you have to taste before the torsion, the vascularization, you have to perform the torsion, and you can see after some seconds, some minutes, that there is a good valid vascularization of the testis. And then there is the software, can you give also the percentage of vascularization after, before and after. I think it's absolutely okay. And as for adnexal torsion, you can perform it in MIS. For this reason, you can use the laparoscopic method. You have to inject before the torsion to check if there is a vascularization, and then you have to perform the torsion, and you see the difference before and after.
There's one more question from the chat. How often do you use it in the management of TEF in your practice? For example, for lymph leaks. I guess not to injure the thoracic duct or to prevent chylothorax after TF repair. I guess that's a question maybe.
I have no experience.
Stefano?
Yeah, I mean, we have used it for esophageal atresia, but mainly to look at the anastomosis. And again, as I said before, it's still kind of empirical to look at how well perfused as the two edges, but we've not seen it for the duct or for the tracheoesophageal fistula.
Yeah. But may I ask you this question, if we are talking about the chest? I wonder why you didn't show any ICG application in CPAM, for example, because, you know, in cases like of an incomplete fissure, you're like digging in there, then you hope you see the arteries first. Why is this not a good indication?
Yes, for sure. We tried when you perform thoracoscopic lobectomy or sequestration to check the vascularization, above all to identify vessels. The only problem is that when you have to identify only the vascularization, the vessels remain vascularized for 30-60 seconds, but then the dye disappears and go in the circulation. But I think that can be, this is a good indication, but we have to develop a little bit better the technique.
Okay.
There's another question that is very interesting. It's from St. Petersburg. Jenny Martinez, St. Petersburg in Russia, says, of course, thanks for this amazing webinar, but also any contraindications on the use of ICG, or should there be any cases in which we need to be careful?
In my experience, in general, if we perform an interview with the parents, if there is an history of allergy to other dye or contracts, it's preferable to avoid to give ICG. But until now, we perform, I think, more than a couple of hundreds of patients without any problem. The only thing is there are some drugs that are an interference with ICG. For example, we operate a child for a cholecystectomy, and this child used phenobarbital, and this drug increased the hepatic metabolism. For this reason, we injected the dye, but the gallbladder was not colored because the metabolism of liver was faster thanks to this drug. For this reason, it's important to ask to the patients if they have some drugs that can have an interference with the metabolism of ICG. Above all, with the liver, you have to operate on gallbladder pathologies.
There's one other question on the biliary tree. When you have stones within the biliary tree, do those affect imaging, like impairs the secretion of the dye or the excretion?
For sure, as I told you, at the beginning of our experience 7 years ago, we start to inject ICG perioperatively to perform cholecystectomy. You can see the biliary tree green, but also the liver is completely green. For this reason, it's difficult to identify the difference. For this reason, we tried several timing of injection, and 12-15 years before is a better way to do it. In this way, the liver is red colored, and you can identify, as I showed in my videos, the gallbladder and biliary tree green colored. For sure, if there is an obstruction, the obstruction can stop the green. It depends if the stones, there is a complete obstruction of the canal or a partial obstruction, but in general, there is a passage and you can see a little bit.
Okay.
There's another question about cholecystectomy, and it's actually quite pertinent one. It says, if the unfortunate event of perforation of the gallbladder, could the ICG cause more irritation to the peritoneum compared to the same situation without the use of ICG?
No, in my experience, we never had a perforation of gallbladder, but there are some reports from adults, because I think that adults adopted this technology, I think 5 years before pediatric surgeons, and there are some reports of perforation without particular problem of inflammation. Another tip and tricks that I can give to the attendees that if, for example, there is, as in the case of phenobarbital, an increased faster metabolism of liver, you need to identify the gallbladder. You can inject directly into gallbladder transhepatically. In this way, you can punction transcutaneously, transliver, and then you go into gallbladder to identify.
There's a question on the role to rule out like vessel obstruction. So the question is, can we use ICG to rule out an obstruction of vas? So I guess like if you have like an embolus or some stenosis of the vessel, whether you can use ICG to inject, or is that my understanding? Do you?
I think it's the vas is the sperm tube. This is what they're.
Ah, okay. Oh, wow. So the rule out obstruction of the vas. So
it could be maybe when you're doing, depends how you do your, if you do a laparoscopic inguinal hernia repair and you do a purse string, maybe there could be that you obstruct the vas and you don't know. I'm just trying to interpret the question.
And you want to feel worse than you feel anyway. Then you can detect that you
better.
obstructed.
Yeah, you're sure.
That's a tough question. Is there any good answer for this question from Mohammed Bahada?
I don't know. I have no experience. In general, I think that in case of, for example, of hernia repair, you can close the peritoneum without having problem on the vas, but I don't know if it's possible to inject the green inside the vas. Probably you have to inject in spermatic I don't know.
But Mohammed, the truth is also, if you injure the vas during a herniatomy or herniorrhaphy, the vas is gone, right? So there's no chance you can repair that in the future, right? That's why when people undergo, adults also, inguinal hernia surgery, and they tell the surgeon to get sterilized via this way, it's no way back. Okay, so
there's a question from Dr. Kutrupi. If you guys have any experience with ICG in patients with G6PD deficiency.
No, I have no experience in this field.
I mean, here I can make a comment, a general comment that we have not touched upon about consenting. You know, we do consent for ICG injection inside the main consent for the operation. And in terms of side effects and risks, of course, there is an allergy reaction against the compound, and particularly if you have, as Ciro explained well, if you have already allergies to iodine contrast, you should avoid ICG. I mean, in the literature, there are also reports about liver failure, kidney failure of contraindication for ICG. And the other thing that is not clear is for example, in premature babies, in premature neonates, or in sick babies with NEC, it is not clear if the ICG could pose more risks. I mean, there are groups around the world, in Australia, that have already published about NEC assessment of bowel perfusion, etc., or midgut volvulus. So it has been used safely, but again, it is an area that is not well explored and known at the moment.
Yes, yeah. I agree with Stefano. I think that the informated consent is extremely important. Also, if the clinical history of the patient is negative from allergy, we put always in informated consent some words that you can have an allergy to this dye during or after surgery. I think that you don't know, but it's preferable always to write in informative consents that you will adopt this technology to have a clear view of the anatomy and to reduce complication, but allergy can happen.
We had an application here at Sick Kids many years ago. We don't do ICG now, but this was when I was a fellow, 2014, for gastroschisis, when this was at the very, very beginning, I think, of the experience in adults, especially. And, when you put the silo, you don't know if the bowel then is well perfused or not. And we used it in a couple of patients, and we presented that at our national meeting here. Martin, I think there's a last question from the chat. There's a lot of people congratulating you both for these wonderful talks.
Right. I mean, there's another question also on whether you should take the testicle out, then whether it helps you in case of testicular torsion. But I think it is the same with the gastroschisis or when in NEC, those are the cases, what is the consequence, right? If you prove by ICG that the perfusion is bad, do you resect bowel early? No. Do you resect the bowel in gastroschisis? No. Do you take out the testicle? No. So I guess it's a nice tool and we will maybe know in the future, but I think these are all indications where an urgent decision is just not needed, right?
Yeah, correct. I mean, highlighting the gaps, it's pretty easy because there is a lot of unknown on the technology and the reproducibility also of the technique in different hands with different devices. So it's true, but the field is moving on quite quickly. So it's exciting. I think in 5-10 years we'll have some of the answers to these questions.
Yes, and then as I told you, we have a lot of experience with MIS, both in laparoscopy and thoracoscopy, but probably also for open surgery, there will be a lot of indication role. I think that the application of with the ICG for open surgery, we had the possibility to speak a couple of days ago with Stefano. Now there are the devices to adopt this technology in open surgery, and probably in the next few years there will be a lot of indication also for open surgery.
Very last question, and then we close. Dr. Gadir Jabber asks if you use it, or if you ever used it for branchial sinus excision to identify the extent of the tract. Any experience with branchial sinus?
We for one patient, we tried this indication using open surgery, but there was a little bit of diffusion of the dye and we have no clear view, but probably can be a good indication. And we have to standardize the technique of injection because if there is a diffusion of the dye, it's difficult to identify. For this vision, I think we have to standardize the technique, but probably can be a good indication.
Okay,
Great.
so I think the take-home message is that you can use it. It's still a very young field, but with a lot of excitement and a lot of applications for in pediatric surgery. There's really clearly a lot of applications, a lot of potential. We're still not there for everything, especially for surgical oncology. I'm a bit scared for some indications, as Stefano showed, that you don't know exactly about resection margins. But it's moving. It's a field that is moving fast, and I'm really grateful to have heard from you guys. You have already a lot of experience with so many applications in different fields of pediatric surgery.
Nothing to add. I put the next webinar dates in the chat. The next webinar will be on achalasia, October the 18th. That's a Wednesday again at 4 p.m. on the medical treatment POEM versus the standard HeLa myotomy plus minus anti-reflux surgery. And then we have further webinar dates November 22nd and December 6th. Yeah. Looking forward to see you there. Thank you, everybody. Thank you, Stefano and Ciro, for the beautiful talks. Thank you, all the discussants. And also Gaia is in her office again. Thank you, Gaia, for setting it up.
Thank you.
I really enjoyed the session, and yeah, wish you all a great rest of the day. Enjoy your time in the rest of the summer, and see you maybe in a few weeks.
Thank
I will
you.
invite him.
Bye-bye, everyone.
So thank you.
Thank you.
Bye.
Bye-bye.
So.